Don't worry, I'll erase all this other stuff.
Thank you.
I'm going to be in the conference room. When you're done,
I'll come to you.
get
Sure. Thank you.
Thank you.
Okay, so today we are going to talk about the evolving theory about suPAR and its role in FSGS, especially in recurrent FSGS. So in order to understand the suPAR and FSGS, let's talk briefly about causes of proteinuria, a little bit of overview of FSGS, and then we'll talk about suPAR. Let's make it a little more educational for everyone. So when we talk about heavy proteinuria, usually we have got primary causes and the secondary causes. The primary causes obviously involve the primary renal causes, which accounts for 70% of our cases. Here the most important categories are FSGS, membranous nephritis, and minimal change disease. For the secondary causes of heavy proteinuria in adults, usually you've got diabetes, amyloidosis, and lupus. Those are main contributory. When we talk about the renal causes of heavy proteinuria, there had been a study done in Spain and Europe in 1994 to 2001 where they had 2000 patients ranging from 16 to 65 years of age, and what they found out at that time was that for all the renal causes of proteinuria, they have membranous nephritis right over here being the most important contributor to heavy proteinuria. The second most important contributor was minimal change disease, and the FSGS was counting on the third cause of primary renal causes of FSGS. What has changed since then? Now we know that the incidence and prevalence of FSGS has gone up. Now the prevalence is as high as 35% versus 15% back in 1976 to 79. We also now know that it is more prevalent in black population, where more than 50% of cases are people who are from African American or who are blacks. Similar study was done in Braden. It was published in American Journal of Kidney Disease in 2000. He did two collection of data at two different points, one in 75 to 79, and then from 1990 to 94, and he found the same thing. He found out that your FSGS incidence or prevalence has gone up from 14% to 25% now, and the incidence of membranous nephritis has gone down to 15% from 38%, and he also found out that it is more prevalent in blacks and Hispanic population. So what is the impact of FSGS? We know that, and this is the data from USRDS, we now know that it is the most common cause of end-stage renal disease in America. The incidence has gone up from nearly 11 from 1980 to 2000, where the incidence of end-stage renal disease secondary to FSGS is now 2.3%. A pathology slide. This is a normal glomeruli. This is FSGS. When we talk about the etiology of FSGS, FSGS is either idiopathic or it's secondary to or is caused by secondary to other injuries to the kidneys or because of the drugs. Part of the problem why the FSGS incidence has gone up is secondary because of the use of medications that we are using more frequently nowadays, including the bisphosphonates, lithium, and cyclosporin, that the prevalence has gone up. If we look at the classification, the basis of classification is done basically it's done according to pathology, prognosis, therapeutic indications, and exclusion of secondary. Obviously, the most important thing to know is that you've got a podocyte alteration in the ultrastructural level that leads to FSGS formation. If we look at the classification, we have got 5 different classes. A tip lesion, where your lesion is located near the origin of your proximal convoluted tubules. The cellular variant, where you have got an endocapillary hypercellularity. The collapsing lesions, where you have got the collapsing glomeruli trough with epithelial cells hypertrophy and hyperplasia, and the perihilar variation where the disease is predominantly located at the vascular pole. As you can see, these are the vessels, and the disease is usually predominantly located at the vascular pole. Looking at the FUGO classification, you've got all these different pathological classification, and if you cannot see any defining lesion, you say this is a focal segmental glomerulosclerosis, not otherwise specified. If we look at the incidence of different forms or variants of FSGS, we now know that FSGS secondary to NOS or not otherwise specified is more common or most common. The tip lesion causes a high proteinuria, but it has got the good thing about the tip lesions are it has got less severe injury and it has got a better renal function, whereas the collapsing worse is the worst type, where you've got patients who are much more younger. They are black patients mostly, and they've got a high degree of proteinuria. This study was done through Chapel Hill, and when they did a median follow-up of around 1.8 years, what they found out that 28% had renal failure, and of those 23% were on dialysis. If they look at the data of collapsing FSGS, they say that collapsing FSGS has had worse 1 year prognosis, 1 year renal survival of 74% and a 3-year survival of only 33%. So age of onset for FSGS is extremely variable. It can occur in 1 month of age to an old age. It is more common in women than in men, and the risk of end-stage renal disease is also more common in women than in male. All variants can lead to end-stage renal disease. And after transplantation, nearly 30% of patients develop recurrent FSGS with poor graft survival, and this is really very important. If we look at the recurrent FSGS, the US RDS 2001 data tell us that recurrent FSGS is more common in younger patient population, is more common in white race, and if you've got a donor kidney from an old donor. What we see is a mesangial proliferation. The recurrence of FSGS can occur within hours, I would say even within minutes to days to several months or years after transplantation, and there can be a rapid progress to anemia. When we talk about recurrence FSGS, graft loss, like I said, is more common in children. Early recurrence is associated with poor survival. Collapsing variety has higher rate of graft loss, and graft survivals of 73% at 5 years in 33 transplanted adults with FSGS. Now, how can we prevent the recurrent FSGS? Obviously, we need to identify the high-risk group, and we already talked about the high-risk group. The other form of prevention is to cure it, and the treatment options that we have got is either use of immunoglobulins, plasma exchange, cyclosporin. The data for cytoxin and corticosteroids are still in limited era. So what is the breakthrough in FSGS? The breakthrough in FSGS came through suPAR, and when I talk about suPAR, I will talk about Superman, because I think this is really cool. So why this is important? This is important because since 1990, FSGS was considered as either idiopathic or secondary to any other kidney insult. Now there has been a significant advancement since then. We now know that there are certain and many proteins that have got crucial roles in podocyte structure, both in structure and function, or both, and therefore they can cause FSGS. We have also now identified certain genetic lesions that can help guide us therapy, and with these lesions, such as the lesions in TRP6C6 and NPHS2 that do not respond to immunosuppressants, but they respond to renal transplantation. We also now know that FSGS can occur as a de novo disease and can occur immediately after transplant and can be treated with plasmapharesis. And this has led to then speculation, and this is very important, how can you treat FSGS with plasmapharesis? What are the factors? There should be some circulating factors that we can remove or reduce the amount with doing plasmapharesis or IVIG. And this has led to the speculation that there should be some circulating factors or permeability factors that can cause high permeability of proteins from podocytes and basically cause altered foot process dynamics and effacement's and causes proteinuria. So structure of podocytes. I always get dizzy when I see this, but this is the ultrastructure of podocyte, which is always very confusing. But to simplify stuff, we know that if we do a podocyte insert, we can induce a cytoplasmic catepsin L, and when the catepsin L gets induced, we can have a motile podocyte. With a motile podocyte, you can have effacement, and effacement can cause proteinuria. Okay, so coming back to our podocyte structure again. So for any good reason, if we induce the catepsin L, we can alter the cytoskeleton here, and if we can alter the cytoskeleton here, this cytoskeleton alteration can cause podocyte foot process. Simplicity. So foot process dynamics, it is not a new concept. It is a fairly old concept. It was first postulated in 1970s, where Sealer found out that if you inject polyketines, it can alter podocyte foot process dynamics, and it can be reversed by infusing polyamines. How cool is that? In 2007, the same principle was followed up, and they found out that the cancer cell also showed the same principle with motility, and when invading different tissues. And we in 2008 used the same principle. We used the same principle to study molecules which were associated with cellular or podocyte motility in vivo and proteinuric disease. What he presented was a substance called UPAR, or urokinase plasminogen activator receptor. I repeat, urokinase plasminogen activator receptor, UPAR, as an important contributor. So what is UPAR then? UPAR is a protein that is expressed in glomerular cells. It is a GPI anchored protein that has protease receptor for urokinase, and this is very important. It has got non-proteolytic pathways through its ability to form signal complexes with other transmembrane proteins. It is important. It has got an important role in wound healing, inflammation, and stem cell mobilization, and recently it has shown to involve in tumor invasions, metastasis, and also in HIV infections. Now this cool slide indicates the UPAR induction in podocytes in proteinuric patients. So the green is UPAR induction, and this glomeruli is from a proteinuric patient. So in the proteinuric patient, this UPAR presentation or UPAR expression is significantly increased, as you can see. And if you can double strain it, double IF with synaptopodin, it gives you a red color. And again, you can see that in proteinuric patients, the UPAR induction is significantly increased. So to cut the chase, what they are presenting is that the suPAR, and the S stand for soluble. So soluble UPAR is released as an inflammatory end product due to any inflammation by neutrophil monocytes and other cells. This suPAR then binds to your beta-3 integrin here. So this suPAR binds to the beta-3 integrin over here. With the binding of the beta-3 integrin, it causes a podocyte effacement, and once the podocyte is effaced, you've got a proteinuria. So this was the theory. Now if we look at the ultrastructure of this theory, what they are saying is that what they are looking in detail is that this is your UPAR protein, this is your UPA, and this is the UPAR receptor, or the UPAR, or the UPA receptor. When the UPA aligns to the UPA receptor with the help of vitronectin, it gets attached to the integrin, especially the beta-3 integrin. This is the beta-3 integrin, and once the beta-3 integrin gets activated through this complex, you've got a series of phosphorylation and tyrosine kinase activity that gets started, and the final end product is activation of your F-actin assembly that causes a bump in your podocyte, and this bump in the podocyte is actually the beginning of your motility of your podocyte, causes the effacement, and this causes the proteinuria. So in summary, what we talk up till now is that UPAR can cause alteration in foot process dynamics. With this alteration, it can cause effacement of foot process and can cause proteinuria. Now the important question is it really so important? If it's so important, how does it cause proteinuria, and how can it be used clinically? And this is where this articles come in. Extraordinary article. I really like this article. The study design was that the suPAR might be a candidate circulating factor in cases of FSGS. It was a multi-centered study. It was done at different centers, big centers, and they measured the suPAR, serum suPAR levels by using either a Contikine human suPAR immunoassay and a ELISA kit. So the human design involved human subjects. So there were 145 human subjects. Most of them have got FSGS, 78 of them. 25 have got minimal change disease, 7 had got preeclampsia, 16 had got membranous nephropathy, and of those 22 were normal. So what were the results of this human study? What they found out that was very interesting. They found out that the suPAR concentration was present in healthy subjects, but if we look at the suPAR levels here, the suPAR levels were significantly elevated in patients who have got FSGS. So this was really interesting. And if we compare it at different glomerulonephritis, the suPAR levels were elevated, but if you compare it with the healthy subjects, the elevation was not that significant. But look at FSGS. Wow, this is great. And when they subdivided the FSGS in pre-transplant population group, what they found out that in the patients who have got a recurrent FSGS, and this was retrospectively done, in patients who had recurrent FSGS, meaning FSGS post-transplantation, their levels of suPAR was significantly elevated as compared to primary FSGS who did not had pre-transplantation, or non-recurrent FSGS whose FSGS were treated after transplantation. And when they look at the data with post-transplantation patients, and the post-transplantation means 1 year after transplant, they found out that the patients who had recurrent FSGS, meaning FSGS recurring after transplantation, their suPAR levels were significantly elevated than non-recurrent FSGS. And if we look at the supplementary data from this study, what they found out that 8 of 13 patients with recurrent FSGS had high suPAR concentrations. So their suPAR concentrations was actually trending up. So before transplantation, after transplantation, when they had a recurrent of disease, if you look at the levels, their levels were significantly elevated. Whereas in non-recurrent FSGS who got treated with the transplantation, their suPAR levels actually came down. And finally, what they looked at is that they found out they tried to achieve a cutoff level or cutoff concentration for suPAR associated FSGS, and what they found out that if your suPAR concentration is more than 3000 picogram per ml, you've got a high incidence of FSGS. So 45 out of 63 patients with FSGS, but only 4 of 11 in membranous nephritis, 1 in 7 of preeclampsia, and 0 of 27 at MCD had a suPAR concentration of greater than 3000 picogram per ml. So this was the cutoff, what they were using or what they have suggested. So to summarize, suPAR serum concentration are significantly elevated in people with FSGS when compared to healthy subjects. No significant variance with suPAR concentration in subjects with MSD, either relapsing or remission types, membranous nephritis or preeclampsia. Higher suPAR concentration with pre-transplantation blood of subjects with FSGS who later develop recurrent FSGS post-transplantation. And high suPAR concentration post 1 year transplant with patients who develop recurrent FSGS compared with post-transplant normal renal function. So while our Superman was cruising ahead, let's talk about the approach of treatment in recurrent FSGS. So in patients who have got a recurrent FSGS post-transplantation, you either go towards the IVIG route or you go towards the plasmapharesis route. And this is very important. It is important because there should be something or some circulating factors, like I already discussed with you guys earlier on, that probably might be increasing the permeability factors or causing the proteinuria in these patients. And then for a rate reoccurrence, you can use either cytoxin, AZE, Myfortic, and if you don't have any response, which is after 6 to 12 weeks, you do for a plasma exchange. So the question arises, how does plasmapharesis can treat your recurrent FSGS? How can it do that? What does it remove? How can it do it? So if we look at the the podocyte ultrastructure again, and this is just for a refresher. We know that there is this complex that gets activated, and this complex causes a cascade of phosphorylation and protein kinase activity and causes a podocyte bump through alteration in your actin and cause effacement and proteinuria. Okay, we all know that, we have learned that. So the hypothesis what they were presenting was that your suPAR levels, the high suPAR levels, will activate your beta-3 integrin in a similar manner as your membrane-bound UPAR in podocytes. And in podocytes, remember, UPAR binds to the integrins, beta-3 integrins. Here you go again, beta-3 integrin, UPAR, binding, alteration in podocyte foot processes. So in this study, what they did was that they measured the beta-3 integrin activity by using an activation epitope recognizing antibodies called beta-3 integrin antibody, or AP5. So now onwards, if they talk about AP5 activity, think about beta-3 integrin activity, and when they talk about beta-3 integrin activity, think about this structure, and when you think about this structure, think about the podocyte effacement and FSGS. Okay. All right. So what they did was they had human podocytes. In those human podocytes, they inoculated with either with FSGS serum or recombinant suPAR. Remember, in FSGS serum you have got a high suPAR anyway, but they inoculated with either with FSGS serum or they inoculated with a recombinant suPAR just to give them higher quantity of suPAR. They incubated it for 24 hours and then looked for immunofluorescent staining. What they also did was that when they were looking for immunofluorescence, they added to this complex either the blocking antibodies to UPAR, or they injected some beta-3 integrin small molecular inhibitor called cyclo-RGDFV, or they just kept the serum in the natural state. So to tell you guys, to reiterate, what they did was human podocyte, they inoculated podocytes with FSGS serum or a recombinant suPAR, and they inoculated it after 24 hours with either the same FSGS serum or recombinant suPAR, or they added a blocking antibody to UPAR, or they added an anti-molecule called cyclo-RGDFV. And then they do the immunofluorescence staining, and when they do the immunofluorescent staining, what they found out that in the bovine serum or the healthy serum, where your serum suPAR levels were low, you have got a very decreased immunofluorescence staining, so very minimum green stain. The sera, when the podocytes where they inoculated the suPAR sera, their inoculation or their immunofluorescent staining was showing a lot of beta-3 integrin or AP5 staining. So the green is AP5 staining. So you can see, if you compare this with this, you can see there was a lot of AP5 staining or a beta-3 integrin activity going on. When they look at the recombinant FSGS serum, look at this activity. Whoa, it's like everywhere in the podocyte. So in all the podocytes you've got the high active beta-3 integrin activity. And then when they put in this sera, so recombinant FSGS sera, which is this sera, when they put the antibody, look at the staining change. So the staining became less, and when they put the anti-molecule here in this sera, look at the staining. So what happened is, what they are trying to say to you guys is that with a recombinant FSGS serum, there was a high AP5 staining, meaningly there was a high beta-3 integrin activity, meaningly there was a high serum suPAR concentration causing FSGS. But when they blocked it either by using antibody or anti-molecules, the activities came down. And when they did the biopsy, they did the AP5 staining, and when they compared it with a control one, look at this, 7 out of 9 biopsies had a good going AP5 staining who had recurrent FSGS, and the same data was presented here, that the percentage of AP5 positive glomeruli was very significant in people who had recurrent FSGS, meaningly FSGS treated with transplantation, after transplantation develop a recurrent FSGS, as compared to patients with FSGS which were primary. So the data is really impressive. And now we need to talk about the recurrent FSGS post-transplantation. Like, what is the phenomena? How does it really happen? What can we do about it? So when they look at the circulating suPAR affecting transplant kidney by affecting beta-3 integrin, they did the same staining again. So the AP5 is staining in green and the podocytes were stained in red. So this red is podocytes and this green is AP5 staining. So before reperfusion, so this is recurrent FSGS. So the patients have already been transplanted, but they have not been reperfused. So before reperfusion, you can see minimal staining of FSGS, minimal staining of suPAR. But when they are reperfused, look at the staining. The staining of AP5 went up significantly, and that shows that there should be some circulating factors that were present in a small amount before reperfusion, but when they reperfuse this recurrent FSGS patient, those circulating factors or proteins literally invaded your kidney, causing such a high staining. When they look at the data with non-recurrent FSGS, the before and after reperfusion, there was nothing. There was no change. So no staining with AP5. They also compared it with normal and acute rejection. This is a T-cell mediated acute rejection, and similarly the staining was negative. Normal and acute rejection, there was nothing. And this is the glomeruli just to compare the non-recurrent FSGS with the recurrent FSGS. In recurrent FSGS, you've got a high staining with AP5, and a high staining AP5 again means you've got a high beta-3 integrin activity, and if you've got a high beta-3 integrin activity, that means that you've got a high suPAR concentration. I think you guys will memorize this by the end of this presentation. So while our suPAR theory is evolving, so evolving Superman, finally carrying the flag of America, let's talk about what is the suPAR and the beta-3 integrin activity during plasmapheresis. Remember, we talk about plasmapheresis, that in recurrent FSGS you can do plasmapheresis to treat these patients. So let's talk about this. The question that comes here is that how does plasmapheresis can treat the recurrent FSGS? The same question that we asked a couple of minutes ago. So what they found out that in your normal sera, in patients who have got a non-recurrent FSGS and in patients with recurrent FSGS, your AP5 activities went up. So in normal sera compared to non-recurrent FSGS compared to recurrent FSGS, you've got a high AP5 activity, and high AP5 activity means high beta-3 integrin activities. That means high suPAR concentration. And when you block the suPAR with the use of either cyclo-RGD or UPAR antibodies, which are the cyclo-RGD again is an anti-molecule, and the UPAR antibodies, the AP5 activity reduce significantly. So does that mean that they've got a high suPAR concentration going on and then you are actively blocking the suPAR concentration? The answer is yes. So finally what they did was that they did a plasmapheresis on this patient. So before plasmapheresis, here you've got a high suPAR concentration, and after plasmapheresis your suPAR concentration came down significantly, and so was your AP5 activity before and after plasmapheresis. So while our suPAR theory and our Superman is standing strongly, what was the effect of our serial plasmapheresis? So 2 of 4 patients who had remission with plasmapheresis, if we look at their protein to creatinine ratio with plasmapheresis, their protein to creatinine ratio came down significantly. So these are the plasmapheresis treatments that they got, and with the plasmapheresis treatments their protein to creatinine ratio came down significantly. And protein to creatinine ratio in FSGS means you've got a good kidney functions going on. The same here. This is the second patient. Your protein to creatinine ratio was here, started from here, you've got the plasmapheresis, and then it significantly came down. In the bottom of the picture, what they are showing is your AP5 activity. So beginning of your plasmapheresis here, your AP5 activity was high, and by the end of the plasmapheresis here, your AP5 activity became low significantly. This is the immunofluorescence staining. Before plasmapheresis, you've got a high AP5 immunofluorescence staining, and after plasmapheresis, you've got minimum. Same here. The patients who did not respond or who did not respond to plasmapheresis, so what happened was that if you look at their AP5 activity started here at the initiation of plasmapheresis, but for some good reason, after a series of plasmapheresis, the AP5 activities did not came down. In fact, it was higher than what it began with. And even in these patients, even though the AP5 activities came down, but it was higher than the cutoff of 2200 mF. Look at this, 2200 mF. So what they are trying to say here is that the disease stabilizing effect of plasmapheresis depends on lowering the individual's serum suPAR to levels that sharply decrease your podocyte beta 3 integrin activity. That means that the plasmapheresis has to be so strong that it should reduce your serum suPAR levels to a degree or to an extent that it should decrease your podocyte beta 3 integrin activity, and if you achieve that, you can have you can treat the FSGS. So just to wrap up, I think this was a very good study. I think this is an eye-opener study. I think this study identified suPAR as a circulating and causative FSGS factor that is elevated in nearly 2/3 of patients with primary FSGS. suPAR mediated activation of beta 3 integrin of podocyte foot processes is the mechanism of injury what they propose, which is caused by high suPAR blood concentration. 70% of subjects with primary FSGS have high suPAR concentration pre-transplantation and remain significantly elevated post-transplantation in recurrent FSGS. The study provides a rationale for more measurable prediction of FSGS risk in subjects with FSGS before and after transplantation. This study can also provide a conceptual framework for refined treatment options that remove or neutralize suPAR to a level insufficient to activate podocyte beta 3 integrin. Full stop. Now, what I would say is that this study was significant, and I think it is an eye opener. I think we can definitely use this study in subgroup of patients in which we can think that they probably might have got a high risk of developing recurrent FSGS by calculating or by evaluating their suPAR levels in their blood or urine. If we can do that, if we can aggressively treat those particular subgroup of patients, I think the outcomes would be much better than this, what we are achieving right now. I think this is definitely a good study. It opens doors to different questions, but definitely it is a worthwhile reading study. With this, I thank you for listening.